State Department of Health, Dr. Kathy Lofi, State Health Officer, Dr. Scott Lindquist, State Epidemiologist for Communicable Diseases, Michelle Roberts, Acting Assistant Secretary, Department of Health, Lacey Fehrenbach, Deputy Secretary of Health for the COVID-19 response, Dr. Sharissa Fotinos, Deputy Chief Medical Officer, Healthcare Authority, Colonel Kevin McMahon, Commander, Washington National Guard COVID response, and Dr. Kira Moseth, Behavioral Health Strike Team Co-Lead, Department of Health. All right. Hold on just one moment. Dr. Lofi, we're ready for you to begin.
Great. Well, good afternoon and happy Thanksgiving to everyone. I am going to share my screen because I do have some slides I want to share with you this afternoon. Great. Well, today I'm going to talk about three topics. First, I'm going to talk about the data issue that we experienced over the weekend. Then I'm going to show you some updated epidemiologic data from our modeling team. And lastly, I will show you some new hospital bed occupancy data from our dashboard. So at the end of last week, we noticed that our data system was not able to process all of the lab results that were submitted to us due to a high volume of results. And we noticed that these test results were starting to back up. This backlog contained both positive and negative COVID-19 results, along with results for our other notifiable conditions that do get reported to the Department of Health. We knew that we couldn't delay getting the positive results kind of through the system and to our contact tracers. So on Saturday morning, we called several of our high volume laboratories and asked them to stop sending us negative lab results for each individual patient. Instead, we asked them if they could send us the aggregate number of negative lab test results that they had each day. As of Monday night, we were caught up with all the processing of all the lab results that had been submitted to us. So all of the positive laboratory results to date that have been received by the Department of Health to date have been included in our dashboards. So we will not be able to update the total number of tests performed or the percent positivity on our dashboard until next week. Obviously, we're not happy about this data issue, but we do have other ways to look at test positivity in our state. Most of the laboratories in our state that are performing COVID-19 testing report their results to the federal government as well as to the Department of Health. And CDC does have an interactive dashboard called COVID Data Tracker that shows trends in cases and percent positivity by county. So if you're interested in looking at percent positivity by county over the long weekend, feel free to check out CDC's COVID data tracker. So now I'm going to move on and show you data from our weekly modeling report. So by now, I think you are all familiar with this slide. The graphs on the top represent Eastern Washington data, and the graphs on the bottom represent Western Washington data. And you can see, starting with the graphs on the left, that the number of daily positive tests or COVID cases is rapidly increasing in both Eastern and Western Washington. You can see that the total daily tests that are performed are also increasing, but the increase in daily positive tests is increasing at a much faster rate. You can also see that hospital admissions in Western Washington are increasing very rapidly, while hospital admissions in Eastern Washington are also increasing, but not quite as rapidly. So this slide shows the new estimated effective reproductive number from our modeling team. And unfortunately, COVID-19 continues to spread very quickly through our population. This week, our modelers estimated that the effective reproductive number was around 1.5 in both Eastern and Western Washington around the middle of November. And as a reminder, any effective reproductive number greater than 1 means our outbreak is getting bigger, which means more each week more and more people are affected. So this slide is a little busy, but I wanted to show it because it demonstrates that COVID-19 activity is very widespread in Washington right now. As you skim over these epidemiologic curves from the different counties in Washington, you can see that our case counts in almost every county are increasing. And in some counties, increasing at a very rapid pace. The graphs that are in purple represent counties that have rates that are higher than 200 cases per 100,000 population per 2-week period. And you can see that now over half of our counties have rates that are that high. Cases continue to increase in all age groups in both Eastern and Western Washington. This graph looks pretty similar to last week. You can see that the greatest increases are occurring in persons who are 25 to 39 years old and 40 to 59 years old. Now I want to turn and share some data on COVID-19 hospital bed occupancy. That was posted on our risk assessment dashboard late last night and is there for you today to take a look at. So for those of you who are familiar with the risk assessment dashboard, you will be able to find this data on the tab that is labeled Healthcare System Readiness. So this graph that we're looking at now shows the number of all staffed acute care beds that are occupied by suspected and confirmed COVID-19 patients. So it represents the total number of confirmed and suspected COVID-19 patients that are in all of our hospitals as of yesterday. And you can see, starting around early November, there were about 450 or 471, I think, persons in the hospital with suspected or confirmed COVID-19. And as of November 23rd, that number had just about doubled. So we're very concerned about how quickly hospital occupancy is increasing with patients with confirmed or suspected COVID disease. So these graphs represent the same data I just showed you, but it shows different regions. So you can drill down into this data and look at the number of persons with confirmed and suspected COVID in hospitals in 8 different regions throughout Washington. I just put 4 of the regions here on this slide so that you could actually see what's happening. And you can see that the number of patients currently hospitalized in King County, Grays Harbor, Lewis, Pierce, and Thurston County, all of our far east counties in the state and in Southwest Washington are all increasing. So we don't have increasing hospital occupancy in just one area of the state. It's really happening throughout the state, which is more concerning to me because then if one single region gets overwhelmed, we have less options to move those patients into other regions. If all the regions are seeing increased number of COVID patients over time. And then the last data I'm going to show you, this slide represents COVID-19 ICU bed occupancy. And that's also rapidly increasing. So you can see, at the beginning of October, we had somewhere around 60 patients in our ICUs with confirmed or suspected COVID, and now we have 214 patients in our hospitals with confirmed and suspected COVID. So in summary, COVID-19 cases and hospitalizations continue to rapidly increase throughout our state, and disease growth continues continues at an exponential pace. And the number of COVID-19 patients in our hospitals has doubled during the past 3 weeks. And if this trend does not reverse itself, hospitals will need to postpone more elective surgeries and will have reduced ability to care for patients with and without COVID-19. So with that, it's always a reminder that people do everything they can in their personal lives to try to slow down the spread of this disease in our community. And that includes making sure that you always are wearing a facial covering when you're around people from outside of your household, making sure that you are physically distancing yourself from people outside of your household, and not having people over at your house. It's just a temporary measure that we all have to take so that we can help slow down the spread of this disease. And with that, I will turn it back to you, Ranji.
Thank you, Dr. Lofi. All right, next we will go to Dr. Scott Linguist. Hold one moment. Okay, go ahead, Scott.
Okay, well, good afternoon, everyone. So as Kathy eloquently pointed out, we are really having a pretty unprecedented increase in our number of cases. And because of that, and with Governor's support, we at DOH are going to increase our employment of case investigators and contact tracers by about 350 employees in the next 2 weeks. The whole goal is within that 2 weeks, really mid-December, being up to speed to handle an increase in this volume. At the same time, we've also had guidance released from the Centers for Disease Control on Monday that really has asked us to prioritize our case investigations and those contact tracings around specific groups. And in particular, they're calling out making sure when you find that case and do that case investigation that we're looking at the family contacts or home contacts, and then also anything that would be a congregate setting, like a business or otherwise. Congregate settings can be long-term care facilities. They could be also big events that we're looking for, and these are affectionately called the super spreader events. So at DOH, we're not just increasing our numbers, we're trying to improve our case investigations and contact tracings, improving the value of our time spent with these cases, and really using these positives or cases to identify their contacts and focus on those contacts, and especially looking for these clustered events or large super spreader events. The specifics of this across the state, in addition to this 350 people that we're increasing, is to have every case to be investigated with very specific questions around contacts and super spreader events. And that every contact will be given direction all along the chain. So from the time they're tested, so the time their contact who is a case is received a positive, they should be getting information along that whole pathway on what to do as a contact. This will also include some additional contact tracing, what we call backwards contact tracing, where we actually work backwards from the case to identify contacts for large events. Specifically looking for these very large events like church events or gatherings, Black Lives Matter meetings, any of these large events where people may not have worn masks. So that is additional work that we will be doing. And at this point, what I'd really like the public to know is we need your help. We need your help when you get tested, that you're clear about what you're going to do with that result. If it's positive, you know where you're going to isolate for that 10 days, that you're already thinking about, well, who are my contacts as defined by within 6 feet for 15 minutes or more. And making sure that you're having a discussion with them, that you're releasing this information to the case investigators, and that you're answering your phone when the public health system calls. That's the big plea for the public, is to have them become part of this solution as we increase our volumes and increase our case investigation and contact tracing numbers, as well as the quality of our investigations. And that is it for me.
All right. Thank you, Dr. Lindquist. Next, we'll go to Assistant Secretary Michelle Roberts. Michelle, go ahead.
Good afternoon, everybody. I'm Michelle Roberts, and I lead the COVID-19 vaccine planning work for the Department of Health. I've got several COVID-19 vaccine updates to share with you today about vaccine approvals, arrival dates, and how the first vaccine doses will be given. The FDA received its first emergency use authorization application for a COVID-19 from a COVID-19 vaccine manufacturer on November 20th. This is encouraging news about the potential for vaccines to be used as a prevention tool to control the pandemic. An emergency use authorization, or EUA, allows the FDA to make a product available during a declared state of emergency before it has full FDA licensure. The FDA's Vaccines and Related Biological Products Advisory Committee is scheduled to meet on December 10th to review the EUA application. We know vaccine safety is important to our communities in Washington. If the EUA is approved, the vaccine will then be vetted by the Scientific Review Work Group as part of the Western States Act. The review by this work group will provide another layer of scrutiny and expert review to the process and should take about 1 to 2 days. This will be done while the vaccine is still being processed and shipped, so it should not cause any delay in making the vaccine the vaccine available to people in Washington. We are hopeful that we will have a vaccine to begin administering by mid-December. The federal government has given us an estimate of 62,400 doses of the Pfizer vaccine for our initial allocation, if the EUA is approved. They have also told us that we should receive an estimated total of around 200,000 doses of the Pfizer vaccine by the end of December, also contingent on EUA approval. Regular shipments will begin in January. We do not have an estimate yet on the Moderna vaccine. We expect to learn more after they submit their application for an emergency use authorization to the FDA. We won't know until early December which facilities will get vaccine first. They will be facilities that serve or employ the groups recommended to get vaccine first. The first people eligible to receive vaccines are high-risk workers in healthcare settings. That's called Phase 1A. We will share more information about vaccine phases in the coming weeks. We've had a question on whether the ultra-cold storage requirements for one of the vaccines, the Pfizer vaccine, will limit who can receive shipments of that vaccine. Fortunately, locations that don't have ultra-cold storage capacity can still store the Pfizer vaccine in a special thermal shipper the vaccine comes in. This allows additional sites to receive the vaccine as long as they can vaccinate at least 975 people in 20 days. 975 doses is the order size of the Pfizer vaccine shipment. We are also working on a policy that will allow hospitals or other people who get vaccine who don't expect to be able to vaccinate 975 people to transfer the extra vaccine to other enrolled facilities. This will help us reduce wasted vaccine. We'd like to also thank all the clinics and pharmacies across the state who've enrolled to become a COVID vaccine provider. As of November 25th, we've had 54 providers fully enrolled, with many more applications partially completed or pending approval. Providers who have fully enrolled in the COVID-19 vaccine program by December 6th will be eligible to receive part of the first shipment. We encourage clinics, pharmacies, and hospitals to enroll in the program soon to make the deadline. Enroll at www.covidvaccinewa.org. And finally, we want to take this opportunity to remind you that even though we don't yet have a COVID-19 vaccine, we do have a flu vaccine. So please get your flu shot. Thank you.
All right, thank you, Michelle. Next, we'll go to Dr. Kira Mosseth.
Frangie, can I share my screen? Great, thank you. Okay, perfect. Thanks very much. Good afternoon, everybody. Thank you for joining us on this really busy week. We appreciate it. I'm presenting for you today an update to our behavioral health forecast. So the strike team has been really busy updating the forecast monthly since the beginning of this pandemic, but this is the first time that we have made a significant change to the response and recovery graph. The chart itself is based on known behavioral health patterns for how people respond generally to disasters of all types, including natural disasters such as a pandemic. And then we kind of labeled it for COVID specifics like outbreak and months post-outbreak and that sort of thing. The update I'm presenting today reflects what we are monitoring around the state in terms of the current spike and the likelihood that we may experience what is referred to as a disaster cascade, in addition to a fairly prolonged disillusionment phase of the recovery process due to the nature of how this is affecting our lives on a daily basis. So there are three main takeaways from this chart. The first one is that we are in the midst of what is clearly the disillusionment phase of the response and recovery cycle. And that is usually the most difficult time for anybody during a disaster. It's hard because of the symptoms that folks are experiencing, and that's particularly with COVID, anxiety, and depression. That's what we're seeing a lot of right now. The disillusionment phase is also really difficult because we're exhausted. It's come up a lot. People are so tired of this. We've been living in this recovery cycle for a long time now and trying to get through it as best as we can. The long-term stress is manifesting for most of us neurologically in ways that really make it challenging to sort of think straight and concentrate, track details, remember things, and regulate our emotions right now. So you combine that with the seasonal changes to weather and daylight, the additional stressors of the holiday season, the political climate, the family dynamics associated with all of that. And the result of this for many people, that all of us or many of us, is sort of this exhausting, toxic emotional soup. And I wouldn't want any part of that at my Thanksgiving table. So it's really difficult. And then we have this third wave of illness that we're contending with as well. So the second takeaway from this chart is that given the dramatic increase in cases that we're seeing right now, there is the potential that this new spike will trigger what is referred to as this disaster cascade in behavioral health. That's not meant to sound dramatic. It represents basically the idea that a community or any population of folks is hit with multiple impacts from different disasters or different versions of the same one within a relatively short period of time. So for families in Washington who have been impacted by the wildfires that we've had over the summer or who lost their homes and livelihoods in those fires, they've already experienced this. It's multiple things happening in a short term. Disaster cascades aren't unheard of. There are many examples of them, but they are very important. And they're particularly difficult when the secondary impact occurs during the disillusionment phase of the original impact. And that's sort of what we're into right now, which is another reason why it's tough. So it's basically a doubling down on the emotional resources and the coping skills that are already really stretched and sometimes compromised for most of us. We're feeling common symptoms associated with this disillusionment phase. And the disaster cascade, if it occurs, is going to extend this recovery cycle, and it's going to increase symptom severity for many people. The third takeaway from this chart is that we will get there. We will recover to our baseline level of behavioral health functioning at some point. The path of that recovery for most people is going to be likely somewhere between the solid line and then the dotted line in the 2021 range, depending on how people are coping and managing right now. So there's a lot of variation in individual responses. Regardless of whether a disaster cascade is triggered or not, humans are incredibly resilient. That is the number one sort of takeaway from this. Resilience is by far the most common long-term outcome for disasters generally. So it might take a little bit longer than we would like, but we will still get there. A vaccine on the horizon definitely contributes to our sense of hope around recovery from this, but even when that's available, it isn't going to change the behavioral health symptoms overnight, right? There's a lot of pieces in the disaster recovery process for folks, but resilience is usually the primary big picture in the long run. That's it for the forecast update. So I'm going to I'll leave that up there for a second. That's fine. If you're interested in more information about the symptoms and the issues that people are experiencing that are common right now, as well as some tips about how to manage them, the Behavioral Health Strike Team is offering a new podcast series called Coping with COVID. We've got 2 episodes out so far, and those are available on the DOH blog, which you can get from the DOH website. So the goal with that podcast is to sort of just provide information from people about what's going on and what they're experiencing, what's normal, that folks aren't alone, and that there are a variety of things that aren't, it's not about working more, it's not about doing more work, it's about working differently and strategizing about how to get through this time and build some resilience. So that's that. The last thing I wanted to mention today is that it's never too late to make a good decision. When it comes to your plans for tomorrow, I know that most people are being really diligent about the guidelines and gatherings, making good choices, but this is really hard. We all miss our families and our loved ones. Disasters are hard to experience and live through by definition, right? So as much as we want things to be normal, holidays aren't normal right now, but it won't stay that way. It won't always be like this, and it won't feel this way. So please keep in mind that for this year, when we don't gather in large groups, when we have smaller sort of household Thanksgiving celebrations than we may like, it helps ensure that when we do gather again, no one is missing because of this disaster and this wave. We all want our loved ones to be around next year at this time. So I'll end with that. It's never too late to make a good decision. Thanks. Back to you, Frangie.
Thank you, Dr. Mosseth. And next we'll go to Colonel Kevin McMahon.
Hey, good afternoon, everyone. Colonel Kevin McMahon. I'm the commander for Joint Task Force Steelhead, which is the Washington National Guard's COVID-19 response task force. This force was established in late March, and we have been continually supporting various stakeholders throughout the state since then. Currently, I have 800 soldiers and airmen supporting a variety of missions, to include food insecurities. We have individuals at 47 food banks throughout the state right now. They have helped distribute over 65 million pounds of food, which equates to about 3.4 million meals. In addition to that, I have teams that are conducting tests. I had 5 teams at one time, and the teams have to date tested over 64,000 Washingtonians. In addition, we're supporting the Department of Health with the development of test kits and also the contact tracing, where we have made over phone calls and have assisted in database entry upwards of 79,000 entries itself. As noted, our service members out in the communities, we are physically supporting a variety of stakeholder communities. And so today what we would ask is for your assistance in protecting that force. So we would ask that people continue to wear masks, social distance, wash your hands, and more importantly, as we head into the holidays, avoid large gatherings. This will help us protect our force so that we can continue to provide the services to the state. So, Frangie, that's basically my brief. Back to you.
Thank you, Colonel McMahon. All right, at this time, this brings us to the Q&A portion of today's briefing. To begin, we will go to Carolyn Bick with the South Seattle Emerald. And before we start, just a quick note, we do have our 3 other panelists available for Q&A. Secretary John Weisman, Lacey Fehrenbach, Deputy Secretary, and Dr. Sharissa Fotinos. Carolyn, go ahead and give me a second. I will unmute you. Go ahead and ask your question.
Great. Thank you so much. This, I think, is a question for Dr. Lofi, but also potentially Secretary Weisman, maybe even Dr. Fehrenbach. But I was curious, and gosh, maybe even Colonel McMahon, but what plans are in place for the inevitable post-Thanksgiving case and hospitalization surge, given all the really bleak statistics we've been seeing? I can't really imagine that the December holidays also will be any better. And one could even argue that the fallout from tomorrow will basically just be a warm-up for December.
This is John Weisman. I'll start. First of all, I think as Kira said, it's never too late to make a good decision. So if folks are at this point considering gathering tomorrow with folks outside of their household, we would ask that you rethink that. and take the safest route. Certainly virtual is best, and we would ask that folks give that consideration. So first of all, I also want to indicate that according, I think it's to the New York Times, when surveying folks across the country, it appears that Washingtonians are the ones who are most thankful and are going to have the least gatherings for Thanksgiving. So we're pleased with that. We believe that people are hearing the message, and we are pleased to lead, hopefully, the nation in that. That said, the additional hiring of the 350 case and contact investigators is part of our response both to the current surge and also would add capacity if that surge continues beyond what we have at the moment. But really, I think the main message for everyone is we need to prevent that from happening. And so heeding all of our advice and continuing to do that, and those who have, we're really thankful for that. We know that this is tiring. We know that people wish it were different, and it will be different down the road. It'll be a very different holiday season next time this year, where we shouldn't be needing to be dealing with this at the level that we are. So asking people to hang in there with us, and as you've heard, we are responding to the current surge.
All right, Carolyn, would you like to ask a follow-up?
No, but I really, I still am curious, because, and I don't mean any disrespect, Secretary Weisman, but, having, essentially basing hopes on the survey conducted by the New York Times doesn't necessarily mean that, Washington won't see a surge, particularly with the, IMHE, I think, the Institute for Health Metrics, predictions for where we're going to be in February, which is a pretty bleak peak, showing that we'll be at least, in the median, more than 9,000 cases per day at the peak in February, and more up almost 54 deaths per day at the peak in, predicted peak in February. And so I am curious what the DOH is, preparing for, given these really grim predictions.
Yeah, this is Kathy. I can jump in a little bit and talk a little bit about hospital preparedness efforts. We've been working with our hospitals, since February now. I remember the first call we had with them and really talk to them about needing to really get ready. And what I can tell you is that our hospitals have been working for months now to prepare for a surge in patients. We're seeing this happen all over the country. And I think a lot of our hospital leaders, very well think that it may happen here as well, too. We're doing everything we can to prevent that. But they have all kinds of plans as to how they can take care of more patients than they're used to taking care of. We call these surge plans. The first thing a hospital can do to make space in their hospital if there's an increased number of patients is that they can cancel their non-urgent surgeries. We know that some hospital systems have already started to cancel some of their non-urgent surgeries, but they could get to the point where they would have to cut back on almost everything that was not urgent. That can help free up some space and some staff in their hospitals to take care of additional patients. The other pieces of their surge plans include things like how they would use different spaces in the hospital. So when, the rooms on the floor get full of patients, they can use other spaces in their hospital, like operating room recovery spaces. If they're doing less surgery, they can use those spaces to take care of additional patients. And they also have plans as to how they can kind of train staff, to take care of different types of people. So you may have nurses that are used to, taking care of patients on a floor, and some of these hospitals have plans to train them and have them work alongside, nurses that are taking care of patients in the intensive care units. So we are working, closely with the hospitals, on types of plans like this, so that they can see, a surge of patients.
The other quick things that I can add, Lacey Fehrenbach, Deputy Secretary for COVID Response, you heard Kathy talk a little bit about planning around hospital and healthcare surge. Our team also has the ability to help surge in supplies to hospitals to help them make more room. I think we are also trying to increase our capacity to box in the virus, so increasing access to timely testing. You heard Dr. Lindquist talk about what we're doing to increase our ability to do case investigations and contact tracing. We also carefully monitor our capacity for isolation and quarantine in the state. Of course, most of the time people can do this in their own homes, and that's what we want them to do. But there are facilities across the state for people who need a place to safely isolate or quarantine. And the goals of this box in the virus strategy really are to stop the chains of transmission. The last thing that I really want to emphasize is it's really hard to predict months out where we will be in the pandemic. We absolutely pay attention to the models that IHME puts out, but I try to think in 3 to 4 week increments, and we certainly plan for the worst and hope for the best. But in terms of the next 3 to 4 weeks, the choices that we make will determine where we are. And those will have amplification effects going forward. So really, we're asking Washingtonians to stay home as much as possible right now. If you go out, wear a mask, keep your distance, wash your hands, and help us turn this around now.
All right, thank you. Our next question comes from Ariel at Spokesman Review. Ariel, you're unmuted.
Great, thank you. My first question is for Dr. Lindquist or Secretary Weisman. Will those additional contact tracers be able to help our local health jurisdictions, especially in smaller communities that are struggling right now to keep up with contact tracing and case investigations? And will they be staffed locally at those local health jurisdictions or based in Olympia?
Yeah, this is Dr. Lindquist. I'll take the first part of this, and the goal is to put these folks wherever they are needed. We are trying to improve the process by putting the people where the highest risks are, and if that's at local health jurisdictions where they need that help, we certainly will do that. Lacey Fehrenbach's probably the best to answer where we would position these folks. But certainly, any place that has a big need would be someone we would put these resources to immediately.
Yes, Scott is correct. These are absolutely here to help local public health. We are positioning them like many of our staff, the majority of our staff remotely at home. And that is part of us doing our part to follow our own guidance and stop the spread of COVID-19.
Ariel, would you like to ask a follow-up?
Sure. It's actually for Michelle Roberts, follow-up on what she mentioned with vaccines. I'm hoping you could elaborate a little bit on our plans to get that first round of vaccine out to communities and rural healthcare facilities that can't take on that 975 doses or whatever you mentioned, isn't a full pallet.
Yeah, great question. So the 975 doses is the amount that can be shipped at once for the Pfizer vaccine that requires ultra cold storage. Wow, I'm struggling with that word today. But so that's the amount of vaccine that will be shipped out at one time. And we know, like you're mentioning, that's probably too much for some of our rural communities. So there's a number of different strategies. First, the good news is you do not need to have an ultra cold storage freezer to be able to store that vaccine. The shipping container that Pfizer has developed is going to be able to hold that vaccine for up to 15 days with additional replenishing of dry ice. And so that's something that we are working on for dry ice solutions, as is the federal government. The initial round of dry ice can actually potentially even be shipped alongside that vaccine so you can change it out quickly. And then the final 5 days of that time period, the vaccine can be in a refrigerator for 5 days. So there's lots of options to get us up to 28 days if you don't have that special type of freezer. So that's really what we're relying on, and we're going to be watching those doses as providers are enrolling their how many people they have in different risk groups, and also are they willing to vaccinate additional people in their community. So maybe if we have a hospital in a rural community, they may not have 975 employees, but maybe for some of the surrounding areas or some of the other clinics in their community where people could come into their hospital and they're willing to do that. So that's the type of things we're exploring with all these sites. And like I said, around day 10, we'll be monitoring that vaccine really closely, talking with those providers about how much they expect to continue to use. And if they can't, then we'll make arrangements to figure out what other providers that are nearby could use that vaccine. And we're working on all the policies and processes to be able to transfer that vaccine safely.
Oh, all right, thank you. Our next question comes from Hannah Scott at Cairo. Hannah, I believe you're unmuted. Let's try one more.
There we go. Hi, good afternoon, everybody. I'm wondering, possibly for Dr. Lofi or Secretary Weisman, we had a report out of Spokane County this week about another child dying due to COVID. I believe that's 4 in the state, between 0 and 19 years old. Wondering if any of you can speak to, offer any insight on that particular death, or anything parents should know, offer any insight.
Yeah, well, we don't really comment about individual cases, very frequently. What we do know about kids is that, in general, kids are less likely to have severe disease, but we know that kids still can be hospitalized and still can die from this particular infection. Fortunately, it hasn't happened very much in Washington. The other thing we worry about with children is multi-system inflammatory multi-system inflammatory syndrome of children. And we have had I want to say around 15 children that have been diagnosed with this in Washington. We do have a report on our website that describes, what we're seeing in terms of multi-system inflammatory syndrome. And we update that, every few weeks. We are tracking, the number of kids. So like I said, we do think the risk of severe disease is generally low for children. But, unfortunately, children can have severe disease as well.
Hannah, would you like to ask a follow-up?
Going on about a plan to change the guidance as far as bringing kids back to school to kind of allow for more younger kids to possibly return to school. I'm wondering if anyone can speak to that and talk to me about a timeline.
Hannah, I'm sorry, can you rephrase the first part of your question once again?
Sorry.
That's okay, go ahead.
I heard that there are some discussions going on regarding schools, changing the guidance that would be put out for schools to bring back younger kids up to 5th grade, I believe, to in-person learning. Can anyone speak to what those discussions are, if the plans are changing, and a timeline?
I can start. We have been, and we have said from the beginning, we would continuously look at the science and monitor the early experiences here in Washington State and nationally as to inform both our health and safety guidance and our school metrics. We are looking at making some adjustments to those metrics. At this point, no decisions have been made, and we don't have an immediate timeline. We're obviously right at the moment very focused on the surge in cases, but certainly when those changes or decisions are made and changes published, we will be reporting and sharing them here and elsewhere.
All right, thank you. Our next question comes from Keith Eldridge at Como.
The question has to do with the 4-week pause on some of the activities the governor's put in place. Is there any indication that when the 4 weeks are over that we're going to be in any better shape at all?
So, go ahead, Kathy.
Yeah. I can start. I'm looking really closely at our data, looking for some early signals that maybe, we may be flattening the curve. Unfortunately, I'm not seeing a lot of positive signals in our data right now, but we will be watching it very closely, for the next 2 weeks, and really decide what the next step is going to need to be.
Keith, did you have a follow-up?
Yeah, it has to do with, I keep asking the governor this, the people with the fitness centers and bowling alleys, there is absolutely no evidence that COVID has had any kind of outbreaks in those kinds of facilities. Why are they on the list of being shut down now?
Yeah, this is Kathy. I can start. So as I think I've explained before, we know a lot more about how this disease is transmitted. And what the science is telling us is that this disease is transmitted when people are in close contact with others for a prolonged period of time. We initially thought that the disease was just primarily spread through large respiratory droplets that come out of our mouths. When we, talk or cough or sneeze. Now we know that very small droplets or aerosols can come out of our mouth and actually linger in the air. And so we really use this understanding of the science around, when we thought about which diseases or, what interventions, might be most helpful. We also know that when people are exercising indoors, one, it's an indoor environment. When they're breathing hard, they are likely producing more aerosols. And so really kind of depended on the science to really make our decisions. So we really, focused on places where people spent a prolonged period of time indoors, with others who were, outside of their household. And that was the reasoning, around, a lot of the decisions we made.
All right, thank you. Our next question comes from Ellis O'Neill with KUOW. Hold on just one moment. Ellis, you're unmuted. Go ahead.
Hi, so my question is about staffing shortages at hospitals. With the number of positive cases we have now, it seems inevitable that there are going to be more hospitalizations in the coming weeks. And I was wondering if there are any, in addition to hospitals themselves, which are already starting to cancel anything that can be rescheduled, I was wondering if there is any plan for a policy to ask hospitals to postpone anything that can be postponed, or if there are any other contingency plans in place for possible coming staffing shortages at hospitals.
Yeah, so we have had lots of discussions, with the hospital system about this, and We really think that they know how to run their hospitals best, and they really understand when they need to cut back on hospital procedures. And they also know when there are people who may need a procedure and may only require a very short stay. And, when they have staff and space available, they can continue to do some of those procedures. So as of now, we're really, letting the hospitals make those types of decisions. And they're all really working very well together. And we have our, Washington Medical Coordination Center that's helping to, place patients if the hospital is more full. And I have to say, I'm just very pleased with how everybody's working together on that. In terms of staffing is a big challenge. I know that a lot of the hospitals are looking for traveling nurses and really trying to, hire as much staff as they can. We do also have a database at the state level with volunteers and we may be able to, provide, some staffing and connect some volunteers to places where they're needed. But staffing, as you mentioned, is going to be a challenge.
Alice, do you have a follow-up?
Yes. So are there any other contingency plans that you're able to do at the policy level in terms of, I know that traveling nurses are hard to find and expensive at the moment just because there are surges nationwide. So there aren't a lot of people available who know how to run ventilators. And so I was wondering, what else can you do at a policy level to make sure that we don't have a shortage of nurses or respiratory therapists here in Washington State?
Yeah, I think more of the action is probably not going to be on the policy level, but more on the hospital level in regards to retraining staff, who may be used to doing one type of care and quickly training them to do different types of care. The one thing that we can do at the policy perspective is if it's really needed, we can consider, changing some of the scope of practice for some practitioners to allow some types of practitioners to do, potentially more than they are normally able to do. So that is, I think, a policy tool that we have, if we, get to that point.
All right, thank you. Our next question comes from Patrick Quinn at Como. Hold just one moment. Patrick, you're unmuted. Go ahead.
And Dr. Lofi sort of just addressed this a little bit with regards to staffing, but as part of the governor's plan, he outlined yesterday potentially more beds will be added into hospitals or pop-up hospitals if capacity is hit. My question is sort of, at what point do these theoretical options become reality and actual? And when do you actually get retired workers or military workers, boots on the ground, into hospitals versus planning for it and keeping them as options?
Well, I can start by saying we do have some beds and some equipment that we've positioned around the state. We did this in the spring and sort of kept some of those beds in position. So we do have some equipment, that can be moved into hospitals if needed, in terms of ventilators or beds and some of the stuff that's needed. Your other question, in terms of when we would have to. So I think that, in talking with the hospitals, I think most of the hospitals really want to, use the space that they have, as opposed to sort of immediately standing up something outside of their hospitals. Hospitals are built to take care of patients. There's oxygen that comes out of the walls. And, there are rooms that allow for infection control. So, I think the hospitals, and I agree that the best place to have patients is in a healthcare facility. And so I think we really want to try to utilize healthcare facilities as much as possible before we even really think about standing up something outside of a healthcare facility. And there are other, there are hospitals, but there are also, some ambulatory surgical centers that also have a lot of the equipment that we have in hospitals, that could potentially be used. And a lot of the hospitals have been working with, their other partners in the community to think about, if they had to go beyond the walls of their hospital, where are those facilities that they would utilize before actually needing to stand up some sort of a pop-up hospital.
Patrick, did you have a follow-up?
I don't know where I'm going with this, but so much in the first wave, we saw so much efforts from states reaching out to the federal government and getting into their stockpile and seeking advice and resources from the feds. It feels like for this second or third wave, there's more interdependence within states. And in fact, Dr. Lofi, you just highlighted you're letting a lot of the hospitals make their own decisions in terms of elected procedures. Well, the difference in mindset, can you highlight a little bit of that? How much of that is true that states, maybe more, they have the time, they've had the stockpile, they're more prepared this time. They're not as reliant on federal help. Is there truth to that? And why the difference in maybe thought process?
Well, I think the big difference is when we experienced our spring wave, it was so new, and we were the first in the country to really have to deal with a surge in patients. And it was, I think, really challenging for the hospital to have patients with a new disease. Healthcare providers needed to wear new types of personal protective equipment, some that they don't normally wear. So everything was new for the hospitals. Everything was new for public health. We didn't really know what to expect. And at this point of the pandemic, the hospitals have reported to me, they said, we've just gotten much better at taking care of COVID patients. We do it all the time. We have people trained to, put on and take off PPE in a safe way. And, they have become a lot more comfortable with taking care of patients. And we understand our data and, how quickly it's, disease is moving, through our communities. And so we've just learned a lot this time. And are, I think, kind of applying what we've learned to, help improve our response.
This is John. I would just echo that. The other thing I would say is that, back in the spring, the supplies were in really short demand. Nobody could get personal protective equipment. We didn't have additional ventilators. Those things have now been secured, and so we're at a very different place. That built with the time to do additional preparation, learning how to treat patients, as Dr. Lofi said, really puts people in a different place to handle a larger volume of patients. All of that said is we don't want to go where you are all talking, and that means we all need to pull together and do our part to prevent us from going there.
All right, thank you. And in closing, I want to thank our panelists for their time today and extend a special thank you to TVW for hosting today's live stream and past archives of these briefings. And that concludes today's media availability. If you have a question or a follow-up that did not get answered, please email us at doh-pio@doh.wa.gov. Thank you.